Good morning. It's a pleasure to join you this morning for the second virtual Congress of the International Spiritist Medical Association. Today I'm going to present a talk entitled Clinician as Healers, and it really speaks to our role in our relationship with our patients, not so much that we are the healers, but we enable the transcendent within the clinical settings, enable that possibility for our patients and their families, but also for ourselves. COVID has certainly cast a light on the critical need for spiritual care. And as outlined in this slide, it triggered a tremendous amount of reflection in the face of uncertainty, in the face of facing our mortality, that of our loved ones, that of our patients, raising deep questions about meaning, purpose, legacy, etc. Many patients and clinicians have suffered spiritual distress, isolation, loss, moral distress, grief, despair, hopelessness, among others. And that sense that we all may have felt and may continue to feel that we cannot fix everything for our patients, and the experience of power of presence in the face of uncertainty. I remember last year I took care of many patients, but one of my patients was near end of life with metastatic breast cancer. And she unfortunately became infected with COVID and was hospitalized at our hospital. And her first night of being hospitalized, she texted me, and we talked subsequently on my cell phone about how no one was answering the call button, how she needed a chaplain right away. She was facing extreme spiritual and existential as well as religious distress, and a lot of pain and symptom management. And she kept pushing that button, but no one came. And her suffering was palpable. It was intense. But on the parallel side, I know those clinicians, and they were doing everything in their power to address the needs of all of the patients suffering distress at that time in the hospital. Now, while I'm talking about this being in COVID, it's also happened before COVID, and it'll probably happen after COVID. We are faced often as clinicians with seriously ill patients, and we're often tired and overwhelmed and trying our best to provide that care. So spirituality is something that is critical for our patients, but also for us. So is transformation possible in the midst of severe crisis? And clearly, one thing that binds all of us is the global experience of severe crisis because of COVID. But our patients prior to COVID who had serious illness, that was a severe crisis for them. Many of us experience crises in our own life. It's just that COVID has brought us together as a community to say, this is hard. We need to find that healing for ourselves. We need to help our patients find healing. So what is that healing? It's that search for meaning and hope and eventual healing. Betty Farrell and her colleague Nessa Coyle have written a beautiful book called The Nature of Suffering and the Goals of Nursing. And in that book, they write, suffering occurs when an individual feels voiceless. This may occur when the person is mute to give words to their experience, or when their screams are unheard. My patient was texting me her screams. My patient was telling me about her screams for the phone. She said, will I die from COVID? Will COVID take me out? I still have things I need to tell my kids before I die. Get me out of here so I can do that. That was her suffering. And that suffering, or other types of suffering that patients experience, they need to have that heard. And our suffering, we need to have that heard. What do patients value most in care? Well, many studies have reported that positive outcomes in terms of patient empowerment and productive engagement in their care and enhanced healthcare were associated with being listened to, being given time, being treated holistically as a person rather than a set of problems, or as a whole person with the biopsychosocial spiritual needs, and as an individual. And when we can hear those stories of our patients, we can really engage in shared decision making, because we know who we're sharing the information with. We have that that relationship that's so important. And when patients were not listened to, the outcomes included distress, suffering, loss of trust and confidence, lack of compliance, inappropriate accessing of services, and poor health and quality of life. So let's focus our attention a little bit on listening. As Henry Nouwen wrote, listening is a form of spiritual hospitality by which you invite strangers to be friends, to get to know their inner selves more fully, and even to dare to be silent with you. Even to dare to be silent with you. So the power in listening is not just asking questions and then thinking of the next question that you might ask the patient, but rather to find that space of silence to really invite the person to share whatever is of their deepest concern. Eric Casal has also written in the first book he wrote was Suffering and the Goals of Medicine, and gave permission to Betty Farrell to use that same title in her book around Suffering and the Goals of Nursing. And in that book, he writes about illness and how that can disrupt the sense of who people are, their meaning and their purpose. Healing may result from reconnection to the transcendent or holy or sacred, however that person understands that. And that also happens within a loving relationship of the patient and the clinician. Well, for us as clinicians to enter into that loving relationship, we need to know who we are, what the sacred is for us, and how that manifests in our care of our patients. Eric Casal goes on to say, transcendence is probably the most powerful way in which one is restored to wholeness. One is restored to wholeness. And he speaks about the profession of medicine as appearing to ignore the human spirit, though I think over these last 20 years that GWISH has been involved in this work, and many of my colleagues are presenting today, I think that's changing, thankfully. And he talks about seeing patients in nursing homes who have become only bodies. I wonder whether it is not their transcendent dimension that they have lost. That is why spiritual care is a human right. Spiritual care is a human right. So how do we open the possibility to patients' healing in clinical care? Well, one is addressing spiritual issues in clinical practice, and I'll talk a little bit about that. But equally important is the practice of compassionate presence. We don't always need advice. Sometimes all we need is a hand to hold, an ear to listen, and a heart to understand. That is what compassionate presence is about. In 2009, Dr. Betty Farrell and I collaborated on a very important meeting called Improving the Quality of Spiritual Care as a Dimension of Palliative Care. And that model, the models from this paper still hold true and are actively used in many, many, many different settings. And I'm going to share some of those with you today. So the summary of that consensus conference is, first of all, that it is a generalist specialist model of spiritual care. So those of us who are clinicians practice spiritual care and the general spiritual care, and the specialists are the chaplains and the spiritual care provider. And ideally, these models are practiced exactly in that way, that clinicians and chaplains work together to care for the patient. As far as the clinical patient part of our clinical role for the clinical generalist spiritual care, we assess, we diagnose, and we treat spiritual distress, including spiritual and existential distress and symptom management. We identify and support spiritual resources of strength. And again, we do this according to our expertise. So clinicians who do histories, assessment and treatment plans, we would do a spiritual history. The chaplains are the spiritual care experts, and so they do a fuller spiritual assessment. That is why ideally we work together. And there are other parts, including provision of spiritual compassionate care, and I will talk about that later in this presentation. So in terms of assessing for spiritual distress, we use these spiritual distress diagnoses that were based on the National Cancer Comprehensive Network and have been elaborated more in our 2009 meetings and subsequently. So it's existential, abandonment by God or others, however people see that transcendent. It's not necessarily only religion or theistic. anger at God or others in their life, concern about a relationship with the deity or with the transcendent, more broadly defined, conflicted belief systems, despair, hopelessness, grief, loss, reconciliation, isolation, and more specific religious and spiritual needs or struggles. So how do we assess for this distress? In a meeting led by Tracy Balboni and others, we joined her in looking at the elements of spiritual distress and screening and how that can occur, as well as many other aspects of this meeting, which included research-based, et cetera. So she developed this overall outline where the type of inquiry can be spiritual screening, and that's usually brief, maybe on admission or in an outpatient setting. It's often integrated into other screening instruments. Spiritual history taking is moderate. I've modified that. It wasn't brief. It's really a little bit more moderate. Open-ended questions using a spiritual history tool such as FICA, and diagnosing spiritual distress and inner resources of strength. And then the spiritual assessment, which is done by the chaplains and the spiritual care experts, is usually at the initial contact. Ongoing assessment, it's much more extensive, and conceptual frameworks are used for that. So let me give you an example of a story, because this is a story of belief in miracles. And Carmen, as a 1-month-old child of a committed, not married, Hispanic Catholic couple, Carmen was transferred to the NICU at birth, 28 weeks, diagnosed with trisomy 21. Her mother would like everything done, but she also declined surgery to correct a ventral septal defect, cardiac defect, hoping to prevent pain and longer hospitalizations. Carmen suffers a few setbacks, cannot be weaned from the vent, and is having trouble tolerating feeds. Carmen's mother says, "We are Catholic. We believe that God will make our daughter well again. We trust God for all our decisions. We attend a Spanish Mass at our church and have not been able to since our child has been so ill." She says we need to continue praying and believing that all will be okay. So these are tough conversations. And the physician starts to discuss options with the mother, and the nurse is at the bedside. He says, "I understand your faith is important to you. Perhaps it's time for you to understand that God has a different plan for your child than you do." The mom reacts with anger and throws the physician out of the room with an admonition to never, never come back again. "You can talk about your medicine, but do not talk to me that way about my God." So what would be healing for this family? Just reflect on what might be healing for this family. So some of the interventions by the team might be to listen to the family's belief in miracles and to their religious and spiritual beliefs without trying to change them. You know that we are so geared as, especially physicians, to try to fix and intervene when we see suffering, and nurses also. Our intent is to relieve suffering as soon as possible. We don't want to see people sitting with that suffering, but sometimes we can't do that. And in a case like this, it's very, very important, number one, to have ideally a chaplain be part of this conversation, but also to listen to those beliefs and not try to cut them off or try to make it try to make a quick fix with this. So listening to the family's belief in miracles and to their religious and spiritual beliefs. Finding common ground. I wish, I hope. Tell me more what you believe in. Explore whether the religious beliefs have other implications in the patient's care. Now, how do you understand it sounds like your relationship with God is really profound. Tell me how you understand that in the midst of what's going on right now with your child. Ask about the patient's family's hopes for their child. Do not ask initially, as that may seem very dismissive of their beliefs, but as you go deeper into the conversation and listen, tell me a little bit about what your hopes are for this child. Practice presence. Suggest ongoing counseling with a chaplain on the team. It's an issue of timing. Trying to first see where the family is and then share, this is what I can tell you from a scientific perspective. So with regard to your beliefs, tell me how that fits, but that happens later in the conversation. So we want to try to think about an assessment and plan for this patient. So we share the scientific data with the family. while aligning with the family about a hope for a miracle. I hope that a miracle happens for your daughter, for your child. But here's what I can tell you, I understand from scientific perspective. What do you think about that? And we want to align our beliefs with their sense and their spiritual beliefs, our scientific data with their beliefs. We want to offer supportive presence to the family, offer counseling services. We may want to refer to the social worker for the family, meeting with the team and the chaplain. And clearly, in this case, a palliative care team needs to be involved. A pediatric palliative care team needs to be involved so they can journey. They can journey with the patient. On the first visit, we may not right away break the news of what we think is going on with the treatment. We want to learn about the family, align with them, bring the chaplain in, bring the palliative care team in. And spiritual, we want to continue to offer that presence to the family, to patients, to the chaplain. And I look forward in our time that we have after this presentation. What are your thoughts on what we can do with this family? So in this family, if we come to some sort of term, if the team comes to some understanding over the family, and it is able to get the family to talk about what they need and that their needs are met, the patient's needs are met, and the team is able to express their concern, who would be healed in an encounter like that? Who facilitated that, and how? Was it the family that was healed? Was it the physician, the nurse, the social worker, the chaplain, the patient? And how did that happen? How did those difficult conversations happen? In my own experience, we just celebrated the 20th anniversary of GWISH, and that was virtual, and we will be sharing the YouTube of that event, which we will share on our through our list and on Facebook, etc. We were very privileged to have Chaplain Kibben, who is the chaplain for the United States House of Representatives. She was interviewed. And one of the things she said about chaplains is that chaplains, when they come into a room, they shed a light on the transcendent in that room. So imagine this scenario. We're in an ICU, lights are flashing, everyone's tense, but the transcendent is there. How do we shed that light on the transcendent? How do we come to understand that in our own selves? She also spoke, Chaplain Gibbon talked about the green space that we operate from. In these hectic moments in the ICU, we may be in the red zone, which is really stressful. But if we can connect to that green space inside of ourselves, that place where for me is the transcendent, that understanding, if we can speak from there, we may be able to help in these encounters to have everyone have their voice heard, and perhaps for healing to occur. So for both the patient and the family, healing is in relationship, that compassionate listening, that presence, that's a key part of it. And why is it not obvious to attend to all of suffering? Cassell, it would seem obvious, but it's hard. It's hard in these circumstances. Cassell wrote, to understand what suffering is and how physicians and also clinicians might truly be devoted to its relief requires that medicine and healthcare and its critics overcome the dichotomy between mind and body. And I would say between mind, spirit, and body. So here's the reality of the clinical settings. And we're just about to start EPIC. So I'm on the cusp of learning a new electronic health system. And it feels like this. It's pretty stressful. And we want to get that data in. That's the reality. And we're pressed for time, etc. And Cassell talked about this as the Cartesian dualism model. Physical pain was relegated only to the physical domain. And the goal was about us and gathering objective data rather than the compassionate and empathic listening it takes to understand a disease in the context of the patient's story. And so that means moving a little bit away from the hectic electronic part of the electronic health record to being in relationship with patients. But that transactional model that we all live with is adding additional pressures, which makes it a little challenging. But is transformation possible in this transactional healthcare system? Can we bring back transcendence, the sacred, into care being open to transformation. That involves radical changes. And that's what we've been about with many of our colleagues, some of whom are in this meeting. These are radical changes that we need to do. And I don't think it's really bringing back transcendence. I think transcendence is always there, whether it's God or the sacred, however people understand it, it's always there. It's that if we turn our focus only to the computer or only to the clock or only to the physical, we are not giving space for the transcendence to shine. We are not giving space to the transcendence to shine. So we need to bring that heart back, that awareness of transcendence, and practice compassionate presence. So we teach about this, about healing and compassionate presence, raising our awareness to transcendence. We teach accompaniment, which Ram Dass said, witnessing, being present. We're all just walking each other home. We witness the present, and that can be integrated within the science of clinical care. So going back to that model from 2009, the other part of that model is provision of compassionate care. But as noted in our 2009 meeting, spiritual development, in order to do that, spiritual development is an essential component of professional development. So what does that mean? Well, in 2008, we had a conference funded by the Fetzer Institute where we met, and Joan Halifax and other leaders were present to talk about models of spirituality and compassion. So spirituality, when we think about spirituality leading to compassion, there are common dimensions to that. I like to think of it as cyclical. Our inner life allows us to be compassionate, but in relationship with our patients, that impacts us and transforms us and impacts our own spirituality. And there are common dimensions: transcendence, our call to service, comfort with mystery, knowledge, desire to relieve suffering, and being connected and supported by others. And we talk about the expressing altruism, providing presence, sharing in our life stories, communicating around spiritual aspects, spiritual needs, etc. And we believe that this type of model can lead to improved patient outcomes, but also outcomes from us, where we find that sense of meaning and purpose in our work. Our own spiritual well-being can be impacted if we practice out of this place of call and service. So let's look at that, the concepts of call and vocation. What is our purpose in life? Do we find meaning in our work? Does it challenge us to grow spiritually? And is our work, job, profession, or vocation? So it's just a job. That's important too, but we're working at one level and we have to do that job. There's no question that doing that electronic health record and filling out the notes is certainly, maybe it feels to some of us like a job, but it's part of our vocation because that's how we care for our patients. We also have professional values for how we behave with our patients and how our call to serve is paramount to that. And then vocation, and that's where all of us are rooted in our vocation to serve. So in this, especially in this critical time of COVID, and now going into the second year of that, are we accessing our passion for this? Does it bring us joy? Are we energized by that? I will tell you from a personal perspective, I can feel incredibly burnt out. But as soon as I'm in the room with the patient or on the computer with telehealth, it brings me back to what calls me to serve with my patient. And those moments are incredibly energizing. So spirituality as part of professional development is having a formation, a reflective spiritual practice to support the work. We need support networks. We need self-care practices, be they meditation, prayer, other practices, and appropriate use of boundaries in clinical care. So presence is a contemplative practice. That's where I see my clinical work it's a spiritual practice for me, especially in being present, connecting from the sacred within me to the sacred to the other, and recognizing that transformation in relationship. I am changed by every single patient encounter, and also with my fellow colleagues. So Dr. Jim Blatt and I, George Washington University, developed a program called G-Wish Templeton Reflection Rounds, funded by the Templeton Foundation, as a way to develop competencies in spirituality and health education. And this is based on spirituality and health curricula that we've been involved in since the mid to late 90s. So we brought schools together. It was a competitive process who have integrated spirituality and health into curriculum. And then we did a consensus conference using a cafe methodology to look at what are the key elements, the national competencies around spirituality and health, published in 2014. And what we found out using the ACGME competencies. So spiritual care is within patient care. It's certainly within communication, definitely within professional development. But we found that since it overlapped, that compassionate presence needed its own competency. So what is that competency? It's a unique subset of compassionate care. It refers to that contemplative aspect of our relationship with our patients. It involves empathy, forming connections, being respectful, caring. Spiritual care at its very root is respectful care. And in this day and age, when we especially know that we need to serve a diverse population of diverse backgrounds, including diverse religious and spiritual backgrounds, this is where something like the FICA tool, which is the spiritual history tool, opens to that conversation for us to learn about the other and how we can respect them. So I think compassion is spirituality in action. So in terms of compassionate presence, it is rooted in our awareness of call, spirituality and transformation, which I've talked about, the practice of contemplative listening. I'm going to share that in a minute. And that our clinical practice is in fact a spiritual practice. How transformational and radical is that? So contemplative listening, a discussion dialogue, and this is from Simon Evers, who is a European chaplain and researcher, and he wrote a beautiful article on this. A discussion technique that facilitates a person's internal dialogue, reflective inquiry, so we can learn to help our patients, learn how our patients focus on their own internal narrative. The primary focus is on how patients talk about themselves, regardless of their religious, spiritual, or philosophical beliefs. And it involves focusing on that imaginary center. To me, that translates into that green space that Chaplain Kibben talked about, that inner part within me that is spiritual, that I connect from that place, particularly at these times when I'm trying to be present to the suffering of another. And in that moment, we are witnessing. It's the patient who's the expert, not us. We're non-judgmental, non-invasive. All the space is taken up by the patient. They use as many points of view as possible, and they personalize convictions into their current personal conviction. And that's an important dialogue. So simply what that means is, as I move into a space where the patient can share, I listen, and I listen to my heart as well as the patient. And so after they finish sharing, my question is not coming from my intellect. It's more coming from that green space. And I may not have a question. It may simply be holding that space. But the question is one of deep reflection to maybe help the patient move deeper into their story. So we want to resist the urge to fix. We want to listen and be rather than do. And we want to resist that urge to lead at those moments of deep listening. It is the patient or the family that is leading the conversation. So we developed a program called ISPEC, Interprofessional Spiritual Care Education Curriculum. We just had our ISPEC this past week, and we had a new content to that ISPEC, which is pediatric ISPEC. We had an incredible journey with our colleagues. And one of our colleagues at the end said, we are developing together, the whole group, we are developing a worldwide fellowship. And that's what it feels like every time we engage in this conference. It's not just passing information to another. It's really collective growth, developing how we can better serve our patients through spiritual care. And one of the parts of ISPEC is an online course, which you can access currently on this site, that it will be on a specific site, which we'll be sending links out on. The third module is on compassionate presence. And in that, we have offered a model from Joan Halifax. It's a model of active contemplative practice. We gather our attention. We recall our intention to serve, or for me, it's again, moving into that green space. We attune to self in another. We consider what will serve, and then we engage in that moment and we end the interaction. So the process is really stilling our mind connecting with our own spiritual beliefs, our vocation to serve. We focus on that intention to serve the other and be fully present. We're aware of the other, which may be the transcendent in the room, not just the patient, as well as ourself. We practice those principles of contemplative listening. We hold that space, silence, no fixing, no judgment, no answer. And we use our own awareness, our intuition to transition back into the clinical aspects where appropriate. So we can begin with, how are you today? What are your concerns? And some of those may be very biomedical. But as we do a spiritual history with using, for example, the FICA tool, or as we hear about a person's suffering, we transition into this space of contemplation, of listening, of being present, of being aware of the transcendent, of using silence as the patient speaks what is happening with them. And when we offer that silence, there comes a moment where we can see they've spoken what is important to them, that you've perhaps asked some reflective questions, and now it's time to transition back to the rest of the clinical encounter. And that is how we integrate our own inner life appropriately. We have awareness of that. That is how we are able to do this, to hold that space. And in that space, there may be that opportunity for that patient or that family to find healing. And maybe we also find healing at those moments. A medical student commented on that module 3. He said, I found module 3 to be incredibly inspiring. I felt chills and familiarity with the motivations I brought into medical school. What has happened since starting medical school is an excessive focus on the technical and not enough of a focus on the sacred aspects of medicine. I look forward to putting these practice these principles into my practice. In particular, I intend to take a pause moment before seeing each patient so as to center myself and become prepared for the sacredness of the encounter to come. That is what it means for us to be present and to afford that space, to bring back that notion of healing into the clinical setting. As the Dalai Lama says, real care of the sick does not begin with costly procedures, but with the simple gifts of affection, love, and concern. Thank you so much for your attention today, and I look forward to our dialogue at the question and answer period.